This is Dr. Weich Coleman. This video is a capsular tension ring use in a case of zonular dehiscence during INA of the cortex. This patient has no history of trauma, no reason for zonular weakness, no known pseudoexfoliation. But you will see the zonules were pretty weak distal to the surgical wound. During cortical extraction, coming up here shortly, distal to the wound, the anterior capsular leaflet is engaged during INA, and 4 to 5 clock hours of zonular dehiscence occurs. It's coming now. Sometimes it's hard to tell whether it's cortex coming across or whether it's the whole capsular bag. Rewind it and look at how clear it is. Looking at the red reflex distal to the surgical wound. And if you look closely, you'll note that it was definitely the whole capsular bag complex that was coming towards the wound. So I'm using my left hand to inject Provisc to inflate the capsular bag and the anterior chamber. Refluxing to let go of the capsular bag and gently removing the INA without any vitreous prolapse into the anterior chamber. This is a 13 millimeter ring inject. They make them in a 12 and a 13. A 13 millimeter works in almost all cases. If you're only going to have one in your OR, 13 millimeter works. You'll see I'm leaning to the right some as I inject the capsular tension ring. It's going around in a counterclockwise direction. That's to keep from distorting the whole bag complex and stretching the weak zonules further as the ring is being inserted. We'll very gently remove the rest of the cortex. And you'll note when the rest of the cortex is removed that you'll see a nice round rhexis with no distortion in the area of the zonular weakness. A characteristic finding if you have zonular dehiscence and you did not place a capsular tension ring is that a round rhexis will then be distorted in the area of the zonular dehiscence. So this case went well. I believe that 4 to 5 clock hours of zonular dehiscence is about the maximum that I would be comfortable placing a lens in the capsular bag. If it's greater than that, many times a capsular tension ring can be used to complete cortical extraction, but I would place a lens in the sulcus because my confidence would be low that the bag is stable enough to hold the lens over a long period of time. Of course, if more weakness is present than that, or larger clock hours of zonular dehiscence, a vitrectomy needs to be performed and a secondary lens needs to be placed at a later date, or a double needle technique can be completed at the time of the case by blocking the patient through the drape and continuing with a double needle scleral fixation. In these cases, I certainly don't go behind the lens to remove viscoelastic. We'll get the anterior chamber good and clear and manage the pressure post-operatively if there is a pressure spike from the Provisc that's left behind the lens. You'll note at the end of that last case, good centration of the lens was noted, and the lens appeared to be in a stable position. If you're unsure there's vitreous present in the anterior chamber, always myostat the pupil and ensure that it's round. Check the wounds very good with a Weck for vitreous. Okay, similar case, distal to the main surgical wound, zonular weakness. You're going to see the whole capsular bag complex come in. There it was. Rewind it if you need to see it clearly, but it's extremely clear behind the area of the zonular dehiscence where the whole bag comes across. The red reflex is poor in this case because this is a retinitis pigmentosa patient with a posterior subcapsular cataract. Again, I'm inflating the bag, inflating the anterior chamber, refluxing by kicking left with my right foot. Again, a 13 millimeter ring inject. We're going to lean to the right side as we insert it counterclockwise to keep from distorting the complex any more than we have to. You can see some distortion of the edge of the capsular rhexis as the capsular tension ring goes in, but after it's inserted correctly, the rhexis edge is very round. I don't hesitate to use a capsular tension ring if I feel that there's any zonular dehiscence or even some zonular weakness. It's a great trick. It can actually be used at the very beginning of the case after the capsular rhexis is made. A gentle hydrodissection can be done, the capsular tension ring placed before the nucleus and the cortex is removed. iComed's got some great videos of this. I'll try to post one myself in the future. A little gentle polish And we'll note at the end of the case, we won't go all the way to lens insertion, but there's a nice round rexus, and I believe this capsular bag will be stable long-term to hold an intraocular lens.